Good afternoon, everyone. My name is Ryan Sindewald. I'm a medical student at UC San Diego and a current MAS candidate. And I'm honored to be able to present my thesis today, which is ICU systolic blood pressure control in patients with subdural hematoma. So a little bit about subdural hematomas. It's one of the 4 types of brain bleeds. In this picture, you can see it in the upper right-hand corner. It's one of the most common neurosurgical pathologies. The incidence is approximately 39.1 per 100,000, and it's increasing annually as the U.S. elderly population increases. Risk factors are quite numerous, but the most commonly cited ones are trauma, antiplatelet and anticoagulation therapy, and age. There are 2 broad categories, acute and chronic, and we're going to be focusing on acute today. Management strategies for subdural hematoma include surgical evacuation, which is commonly a craniotomy, potentially an MMA embolization, which is a newer treatment, but also conservative management is critical. And within this, systolic blood pressure control is of the utmost importance, and that's what we'd like to investigate. So what are the current guidelines with regards to the maximum systolic blood pressure control in patients with subdural hematoma? The short answer, there really isn't one. Ultimately, there was a recommendation made by the American Heart Association for all intracranial bleeds, keeping systolic under 140. Brain Trauma Foundation doesn't list an upper bound for the systolic blood pressure because it hasn't been properly investigated yet. So I did a systematic review on the subject. I did find 3 studies that looked at systolic blood pressure in patients with subdural hematoma, but I didn't really find anything that was conclusive. So the first one, published in 2018, looked at just a single systolic blood pressure measurement in the emergency department. And they did find that it was positively associated with hematoma volume, or change in hematoma volume. The second one, also in 2018, looked at the maximum postoperative systolic blood pressure in patients with craniotomy for acute subdural hematoma, so patients who got operated on. And they actually found something that's quite the opposite. People who developed post-craniotomy hematoma, so the hematoma came back, actually had decreased blood pressure. The largest one that I reviewed in 2022 was Plowman. They looked at both the mean systolic blood pressure and the maximum systolic blood pressure within 24 hours of admission, and they did find that hematoma expansion was more likely in patients who had systolic blood pressure above 140. But at this time, it's unclear what the actual proper blood pressure recommendation is. So we decided to investigate this using the MIMIC-4 data set. So our theoretical blood pressure curve, which you can see on the right, exemplifies the 3 metrics that we wanted to look at in this patient population. For when patients go above 140, it could be potentially the maximum systolic blood pressure, A, that's important. It could be the time that they spend above 140, B, or it could be an interaction between the 2, the area under the curve, which is defined as C. No study to date has investigated this physiologic anatomical interaction like this. And so this is our graphical abstract. Essentially, in patients who have a traumatic subdural hemorrhage, they come into the ICU and systolic blood pressure in a combination of these 3 metrics may be important, and we want to look at the outcomes the outcomes with results in mortality, or the outcomes of mortality, essentially the operations or their history component, imaging frequency, which would be CT scans in this case, or exam findings, which in the MIMIC-4 database is exemplified within the GCS. So what is our research question? In subdural hematoma patients in the ICU, do patients with inadequate blood pressure control, as defined by greater than 140 millimeters of mercury, have statistically significant differences in reoperation, CT imaging, neurological decline, or death rates? Each one has its own hypothesis listed below. So what did our cohort look like? So we pulled from the MIMIC-4 data set, and the reason why MIMIC-4 is because it's the first of its kind. It was updated this past summer to include continuous ICU vitals, and ultimately 1,141 patients met inclusion criteria, which was simply that they had a subdural hematoma, and they also had continuous vitals within this data set. We also collected socioeconomic factors, such as age, age, and sex. We collected the specific diagnosis, which were a combination of ICD-9 and 10 codes, and also ICU stay data, which specifically we wanted to look at that ICU start time for that critical 24-hour window. We also pulled the arterial systolic blood pressure, the numeric value and the time collected, to know what values came in what order and whether or not they fit within the window. We also looked at the outcome variables of death, operation, CT scans, and Glasgow Coma Scale score decline, which is a surrogate for the physical examination, which I'll explain later. On the right, you can see a demographic breakdown of this data. So I want to talk about the outcomes a little bit. Death is pretty obvious. We'd want to look and see whether or not there was any mortality associated with this. That was our primary outcome. Our secondary outcomes were the history, which we sort of defined as the craniotomy or craniectomy. When dealing with subdural hematoma, you want to look at a mix of history, physical exam, and imaging in order to decide your management. And for what we were able to collect from the MIMIC-4 data set, operation represented our history. Our imaging was represented by CT scans, and we defined our outcome as having more than one CT after their stay in the ICU. A lot of these patients are trauma patients, and they may have gotten more than one CT prior to getting to the ICU, so we want to know what happens after ICU takes over. One CT within that window is pretty normal. 2 means that there may be something wrong. Physical exam. This is where the Glasgow Coma Scale score comes in. So the scale runs from 3 to 15, with higher numbers being closer to what we consider normal neurological function. It's made up of eye, motor, and verbal components, and we wanted to look at how this changed with respect to ICU blood pressure control. So we defined a significant GCS change as 3 or greater. Simply closing your eyes lowers your GCS score by 1, so 1 would be insufficient to look at a significant change, so that's why we defined it as 3. So my statistical methodology was descriptive statistics for the patient population, which I've already shown, univariate analysis for primary and secondary outcomes, which are 2 independent sample t-tests for normally distributed data, and Mann-Whitney U-tests for non-normally distributed data. I also did a multivariate analysis for my primary and secondary outcomes, which I used logistic regression for. Moving on with mortality, you can see that with all A, B, and C, both looking at in-hospital mortality and 30-day mortality, both present in the data set, they were not statistically significant. Now, death can be a sort of a very noisy signal, and so we weren't expecting to find anything here, but ultimately we found that there was not a statistically significant association. Moving on, for operation, similarly, we also found that there wasn't any statistically significant differences between blood pressure in patients who received operation or reoperation, though you can see in reoperation there is in general, qualitatively, higher blood pressure, higher time over 140, and higher area under the curve. And the p-value is trending a little bit more towards statistical significance than in just the operation group, but still nothing that we can definitely say is statistically significant. Moving on, here's where we start to get some really interesting findings. With CT scans, as I've said, defined as having more than one or greater, we find that it is very strongly associated with having higher maximum blood pressure, and there is a statistical association with or a statistically significant difference in the amount of time that someone spends above 140 and the area under the curve, both greater in people with multiple CT scans. Running a multivariate analysis on this, I found that with doing a logistic regression with a backwards model selection, accounting for socioeconomic variables such as age, range, and sex, and dropping those with a p-value less than 0.2, which is standard practice, that only the maximum systolic blood pressure remained, and all the socioeconomic variables dropped out. This here I'd like to spend a little bit of time on. So these are 2 normalized histograms which overlap. The turquoise histogram are people who received multiple CT scans, and the salmon are those who did not. You can see that in general, the turquoise histogram seems to overlap the salmon histogram as the maximum systolic blood pressure on the x-axis increases. Additionally, the odds ratio, which I have at the top, increases with each threshold. That first vertical red line is our cutoff 140 that we selected. Each additional red line is 10 extra millimeters of mercury of their maximum blood pressure. And you can see that in general, the odds ratio grows as you add 10 more. This illustrates something of a dose-response relationship with maximum blood pressure and our CT outcome, something that we would expect based on the proposed pathophysiology. Specifically, the reference group in these odds ratios are people who had perfect blood pressure control, those who are to the left of that first red line. As you get to the very far end, you see that the odds ratio seems to drop. Potentially this is because very few patients were in that area, but we would expect that the confidence interval for that odds ratio would also be large. Looking at the GCS now, again, we defined a significant change as 3 or more. We looked at 2 different versions of this. One was the total change that you saw, the maximum and the difference between the maximum and minimum GCS. And then we also looked at the GCS derivative in the time points that we have within the data set, whether or not there was a sudden decline. Looking at the range, there's a very strong statistically significant difference between those who had a significant change and those who did not, showing higher maximum blood pressure, higher time above 140, and higher area under the curve for those who had a significant change. In the GCS derivative, it's a little less clear. The p-values do tend to be lower in those with more time under the curve, or for area under the curve and for more time above, but no statistically significant difference can be taken from that. Moving on to the multivariate analysis, I did 3 models, as I did before, but only in the previous one, only the maximum systolic blood pressure was significant. In this, all 3 of them remain statistically significant on multivariate analysis. You can see that the socioeconomic variables, one of them was still retained, which was the Asian race. In order to make room within the slides, I only kept the statistically significant variables. Moving on, I have a similar graph of the overlapping histograms and odds ratios, and it again shows a very similar dose-response relationship for maximum systolic blood pressure and the odds ratio. And again, it shows that as you move further and further to higher blood pressure, the turquoise, the ones that had GCS change, versus salmon, those that did not have the GCS change, seem to overlap. So what did we discover? Maximum systolic blood pressure time above 140 millimeters of mercury, and area under the curve are correlated with increased imaging frequency and GCS score changes. And this suggests that maintaining a blood pressure under 140 millimeters of mercury, and especially preventing spikes as the maximum systolic blood pressure seem to be the most important universally, within the first 24 hours of care is important to improving patient outcomes. Higher blood pressure values lead to increased odds of developing GCS score changes and receiving more CT scans, as shown by my second 2 figures. And what's kind of unique about the study is it demonstrates the direct interplay between anatomy and physiology. So, as with all studies, mine has limitations. It demonstrates an association, but not causality. We cannot determine that with this study. Ultimately, we would need more information and other study designs to determine this. The temporal resolution of the blood pressure measurements is on the order of an hour. A lot can happen in an hour, but I think that we were able to show with even this temporal limitation that there is strong association. It is also a single center data set. MEMIC4 is based out of one institution, and there's no specific radiological data available to us. So we don't actually know for a fact whether or not the hematoma expanded. We can only show outcomes and association with systolic blood pressure. Where would I like to take it from here? So current practices have 140 as the limit. You can see from the histograms that there actually was, the overlap did start around 140. It may be the magic number, it may not be. It may be more complex than that. So we'd like to investigate that. And we'd like to do so with UCSD data, which would be higher fidelity and higher temporal resolution than what's available in MEMIC4. And we'd like to investigate what the best cutoff value for patient outcomes really is. Additionally, we'd like to look at an analysis of how blood pressure medication is administered in the ICU. It is titrated and it can be complex with different blood pressure medications having different potencies, and ultimately requires its own investigation. Additionally, multi-center analysis would always be great and improves the generalizability of the data. And ultimately, we see this moving toward a quality improvement or clinical trial for acute subdural hematoma management, hopefully with UCSD leading the charge. So, in conclusion, inadequate blood pressure control in the ICU in subdural hematoma patients is correlated with repeat CT scans and large change in GCS score, suggesting hematoma progression in this study. At this time, I'd like to thank Dr. Alexander Kalesi, who's my mentor on this project, Dr. Cuomo, who's one of my teachers and the chair for my committee, and who taught me everything I know about SQL, Dr. Santiago Diepa, who's been a mentor of mine throughout med school, Dr. Hirschman for his statistics experience, Dr. Macedo for her contributions to my project, and Dr. Vita, who taught me pretty much everything that I know about statistics. And also for the MedGap program for funding this research year that I'm taking between years 3 and 4 before I apply into neurosurgery. Happy to take any questions at this time.